Hello, and welcome to the CAP Today webinar for Tuesday, March 11th. I'm Bob McGonigal, the publisher of CAP Today. I'll be your host, and I'll also moderate a question and answer session after our formal presentation. Today's webinar is entitled The Journey to Fetal RHD Genotyping for Targeted RhIG Prophylaxis. This is a very famous topic that's historic, and we have a lot of new information from new folks, and we're just delighted to be able to present this topic because it's very important still, and it's made possible this webinar today by a special educational grant from Devicer. That is a newer company that's based in Sweden, and we're going to hear about their experience in Canada. And it's a real delight to be working in this topic area. We want to acknowledge them and thank them for their support in allowing us to present today's important session. We have two very distinguished speakers, and I'll say more about them in due course. Dr. Gwen Clarke is professor of laboratory medicine and pathology at the University of Alberta. Dr. Nancy Robitaille is a vice president of transfusion medicine at Heme Quebec. She's also at Saint Justine in Montreal, and she is a clinical professor of pediatrics at the University of Maryland. Now, before we begin, I just want to share some tips with all of you. You'll see on your screen a Q&A pad or pod, and you can use that. You can use that pod on your screen to report any technical problems, whether it's with this website that you see or it's with the audio. We have live help. They'll be available throughout today's webinar to help you. Of course, the Q&A pod that I've just pointed out is primarily for your use to make comments and to ask questions of our speakers. And again, that'll be open throughout. We'll collate those comments and triage them, and we'll post them to our speakers after our formal presentation. We plan to post the full webinar for your use and your sharing with colleagues at captodayonline.com. That'll happen in about a week. We'll have some follow-up emails that you'll see from us and likely from our very good sponsor, Devicer. Finally, I want to let you know that, as always, CAP does not endorse any product or service that may be mentioned today. And any comments of mine, of course, are purely personal. They're not to be taken as policy or a position of the CAP Today or the College of American Pathologists. And with that, I would like to begin today's webinar. And our first speaker will be Dr. Gwen Clarke from the University of Alberta. Dr. Clarke.
Thanks, Robbie, and thanks to the sponsors for inviting me to present today on what has really been one of my favorite topics over the last decade, and one which I hope we'll continue to hear a lot about over the next few years. So the title of our presentation today is The Journey to NIPT for Fetal RHD in Canada. And I want to start by telling you a little bit about the history of anti-D-mediated HDFN, just reminding us where we are today, and the role of Rh immune globulin prophylaxis in reducing the impact of this disease. I'm going to go on and talk a little bit about what I consider the benefits of RHD genotyping to target Rh immune globulin prophylaxis to only those who require it. Then I'm going to hand you over to Dr. Robitaille, who will lead you through the steps to successful implementation of NIPT testing, at least as we've experienced it in Canada. So I'll start by introducing you to three clinician scientists who are really pillars of the Rh immune globulin story in Canada and really around the world. On the left is Dr. Bowman, Dr. Jack Bowman. In the middle is Bruce Chown, and on the right is Alvin Zapersky. And all of them were involved in work in the 1960s and beyond, which was really pivotal in establishing the current program of Rh immune globulin prophylaxis. Dr. Zapersky in particular, you'll see, only died very recently, and right to the end of his career was involved in trying to ensure that HDFN due to anti-D was more effectively conquered around the world and not just in high resource countries. So, what did these guys do? Well, in the early 1960s, there were two pivotal studies on either side of the Atlantic, one by Frieda and colleagues out of New Jersey, and a second a few years earlier, actually, by Dr. Finn and colleagues in Liverpool, that really established that, in fact, anti-D immune globulin, when administered to RhD negative individuals, could prevent the development of anti-D. So those studies were then followed up by Bowman and colleagues with some really good work on establishing what at that time was state of the art with respect to diagnosing and treating RhD, anti-D mediated hemolytic disease of the newborn. And then Dr. Zapersky's work in the 60s was really important. This study actually established that fetal cells were present in the maternal circulation throughout pregnancy, even in the absence of complications. So this was the first paper that really looked at, were there fetal cells present in mom's circulation early in pregnancy, even if there was no event, no immunizing event, no trauma, no procedure. So these were all important studies that led subsequently to two clinical trials, which really established the program that we still recognize today in Canada. So the first of these was a clinical trial that was run between 1966 and 1968 in Manitoba in Canada. And this was Bowman, Chown, and Zapersky that were involved in it. And this was a trial where they administered the Rh immune globulin postnatally to RhD negative women who did not have anti-D yet, and in whom the baby was found to be Rh positive following delivery. So cord testing established that the baby was Rh positive, the woman was Rh negative with a negative antibody screen, and they were given Rh immune globulin postnatally. And this postnatal prophylaxis, which was targeted again to those who had an Rh positive baby, was very effective in dramatically reducing the amount of anti-D alloimmunization and by extension, the amount of anti-D mediated HDFN. It didn't eliminate it entirely, however, and they knew from Zapersky's studies that there were likely to be immunizing events earlier in pregnancy, even if there was no recognized pregnancy complication. So they went on to a second clinical trial, which was published about a decade later in 1978. And in this trial, they added to that targeted postnatal prophylaxis a routine dose at 28 weeks. And this was given to all RhD negative women who had no anti-D. Of course, at that time, they did not know what the fetal RhD type was, so it was called routine prophylaxis to distinguish it from the targeted approach that was postnatal. And this again further reduced the amount of anti-D alloimmunization that occurred in these pregnant individuals. So these were really pivotal studies, and they led to what is still our timeline for testing an anti-D immune globulin prophylaxis 50 years later in Canada and in many places in the world. So what we do up until the point at which genotyping is introduced is an early ABO-Rh and antibody screen, generally somewhere around 12 weeks gestational age. And then in many pregnant individuals, a repeat ABO-RHD type and antibody screen is done around 24 weeks. And this is really considered to confirmatory that there is no anti-D that has developed in the interim. So then in those individuals who are RhD negative with a negative antibody screen, anti-D immune globulin, Rh immune globulin, is routinely given at about 28 weeks gestation. Then, following delivery, a targeted dose of Rh immune globulin is given to only those individuals who are shown to have an Rh positive neonate. So in other words, those at risk for anti-D development because the baby cells could immunize them. So currently we have then this routine dose at 28 weeks and a targeted dose to only those with Rh positive babies at gestation or following delivery. I'll just note that additional doses of Rh immune globulin are given for episodes of potential FMH throughout the pregnancy. So for example, if there's an intervention like an amniocentesis, or if there's trauma or a threatened abortion, for example, or vaginal bleeding after 12 weeks gestation, all of those might be additional potential immunizing events for which Rh immune globulin may be given. So this is really the timeline for routine pregnancy care. And as I say, it's continued ever since that clinical trial from 1978 until today. And what has this done? Well, it was found within those clinical trials that with targeted use of postpartum Rh immune globulin, a 15% alloimmunization rate dropped to about 1.6%. So that's pretty good. But once you introduce that routine dose antenatally at around 28 weeks, that 1.6% alloimmunization rate decreases further to less than 1%, somewhere in the neighborhood of 0.5 to 0.8%. Of course, Rh immune globulin failures and missed doses or inadequate doses do continue to occur on a population level. So anti-D related hemolytic disease of the fetus and newborn has not been completely eliminated. And the prevalence is about 1 in 21,000 live births. But of those, severe anemia only occurs in a minority, probably about 10% of those at risk, meaning those where the mom has an anti-D and the fetus is D positive. And then mortality, in fact, in high resource countries where there is availability of intrauterine transfusion, the mortality remains quite low at about 0.5 per thousand live births. So since the early 1960s, where there was high mortality and high alloimmunization rates, we've really made a huge amount of progress. So what about a new strategy then that would target that antenatal Rh immune globulin prophylactic dose? So as I mentioned, the postnatal dose is typically targeted only when we know the neonate is Rh positive, or if for some reason we can't determine the neonatal Rh type. But the antenatal dose, unless you introduce genotyping, is not targeted. It's given to everybody that's RhD negative without an anti-D. So how can we do better? Well, we can introduce genotyping for the RhD gene using non-invasive prenatal testing from this stuff called cell-free DNA that's present in maternal plasma. So it turns out that maternal blood always in pregnancy contains cell-free DNA. And this was established by Dennis Lowe and colleagues, published in The Lancet in the late 1990s. Further studies showed that this cell-free DNA was present very early in pregnancy, as early as 7 weeks gestation. And not long after those discoveries, it was established that you could genotype for a number of things, and this is in common clinical use for other disorders. But for fetal RhD type prediction in particular, it was shown to be as sensitive as postnatal serology as early as 2008. So how does this work? Well, if you have this pregnant individual who's RhD negative and is carrying an RhD positive fetus, today, we don't know whether that fetus is RhD positive or negative, so we routinely give Rh immune globulin if the mom is RhD negative and does not have an anti-D. But of course, if we could figure out whether the baby was Rh positive or negative, we could change that routine prophylactic dose to a targeted dose to only those women who have an RhD positive baby and not give it to anyone who has an RhD negative baby and is therefore not at risk for alloimmunization. In North America, we are late to this party. So this is a slide from a few years ago in 2020 showing that many countries have implemented this kind of testing on either a national or regional level more than a decade ago. So Belgium, France, and Sweden had some testing as early as 2009, with Denmark, the Netherlands, Finland, and England introducing it soon after that. So all of these places have established large-scale programs, and this is just the tip of the iceberg. Many, many countries around the world have established this testing. And further to that, there have been many external quality assessment workshops that compared the results of these various programs. And these QA studies demonstrate that despite quite different approaches taken to perform the clinical assays, that fetal RhD genotyping is a very reliable laboratory test that can guide targeted Rh prophylaxis in a clinical setting. So it's available, it works. And here's a study just showing us a little bit about how sensitive it is. So again, here's a list of countries that have large, either regional or national programs. And you can see that they have very different approaches. These are the RhD gene exon targets that are used in the various programs. And you can see they range from 1 to 4 exons that are used in various programs. So really different testing approaches. They're also done at a variety of gestational ages. So some as early as 11 weeks and others as late as 27 to 29 weeks and everywhere in between. But across those varied kind of program parameters, the diagnostic sensitivity remains very high, greater than 99.9%, and the confidence intervals are very narrow. So in general, this is a very sensitive and specific test. There have been a couple of systematic reviews and meta-analyses that have looked at all of the published studies from the countries with national and regional programs. And all of them are very positive with respect to the efficacy of this testing. They agree that this test is safe to use from 11 weeks onward. In other words, there's enough cell-free DNA with particular assays to carry on this testing, that the tests are in general very high sensitivity and specificity, and really the testing has gotten better over time, and that in general, these tests are sufficiently accurate for widespread use. So we're on a solid foundation with respect to introducing this change in the strategy that we use for targeting Rh immune globulin prophylaxis. One of the other questions is sort of an economic analysis. Does it actually decrease Rh immune globulin use? So can you correlate the use of this new test to a decreased use of Rh immune globulin? And in fact, there have been many studies that show that this is the case. So across all studies, which would involve populations with different prevalence of RHD positivity, 25 to 39% of genotype pregnancies managed to avoid unnecessary Rh immune globulin use. So in other words, you compare reduced Rh immune globulin use and cost with the performance of this test, and to some extent at least, depending on the test used and the healthcare system economics where you live and work, you can offset the cost of the test with a reduction in Rh immune globulin use. So in Canada, we started looking at this, the process for implementation quite a few years ago. Certainly our process was sadly interrupted by the COVID pandemic when all of our attention turned elsewhere. But in about 2017, a group of transfusion medicine physicians, obstetricians, fetal medicine physicians, and scientists got together and wrote a guideline that was really intended as a bit of a call to action for blood suppliers and funders, which in Canada are provincial governments, with respect to taking a look at routine non-invasive prediction of fetal RHD. And this call to action was quite effective in the sense that it got the attention of funders, and a number of subsequent pharmacoeconomic analyses took place. In the paper, we really go over a number of reasons why it's a good idea to do this. So why consider this screening for RHD and NIPT? Well, the first pillar maybe is the ethics of the thing. So is it ethically acceptable to continue giving Rh immune globulin when an alternative is available? So we know there's a substantial proportion of RHD negative individuals at 28 weeks that get this drug that don't need it because their fetus is Rh negative and there's no chance of alloimmunization. So introducing this testing is really an ethical imperative in terms of reducing this use of an unnecessary drug. Also, we produce RhIG by immunizing blood donors, which maybe is not an ideal circumstance, and reducing the need for this might be an improvement. In addition, it's a globally responsible approach. So we know that worldwide, Rh immune globulin is actually in quite short supply, and that Rh diseases continue to be quite a scourge in developing countries. So if we could make more Rh immune globulin available, then more individuals who could benefit from protection from immunization would be possible. We would also join our international partners in providing state-of-the-art testing to support optimal practice. And in addition to conserving Rh immune globulin, reduce lab tests and clinic visits for pregnant individuals, alleviate patient discomfort, inconvenience, and anxiety, and really comply with the spirit of choosing wisely, which would say don't transfuse blood if other non-transfusion therapies would be just as effective. Rh immune globulin has been very safe over the 50 years that it's been in wide use, but there is still certainly a theoretical risk of transmission of viral and prion infections, and so we would eliminate that risk in those that don't get the drug at all. And finally, and maybe most importantly, we allow women to make an informed choice about the use of Rh immune globulin administration, and in so doing, perhaps improve adherence to anti-D treatment. So with that background, I'm going to turn the slides and the talk over to Dr. Robitaille, who will take you through the steps to successful implementation of NIPT testing in our jurisdictions. Thank you.
Thank you, Dr. Clarke. So as Gwen has just stated, during the 15 to 20 minutes, I will describe the different steps we are taking at EMO Quebec to implement NIPT testing in the province of Quebec. So as you're probably aware, in many European countries where NIPT for fetal RHD has been implemented, testing is offered by blood establishment. Canada is going in that same direction, and the two blood operators in Canada plan to deploy this test within the next 12 to 18 months. EMO Quebec will offer the test for the province of Quebec, and Canadian Blood Services, also called CBS, will offer it to the rest of Canada. Both organizations work in close collaboration, and we will be each other's contingency plan. One important thing to remember is that the steps toward implementation will differ according to your environment and your healthcare structure. One of the most important factors to consider is the program scope. Are you deploying a national or local hospital-based program? The implementation of the assay in itself is quite straightforward. The main challenges are the pre- and post-analytical phases, and as you will realize during my talk, this is particularly burdensome when you implement a national program. Other factors to consider are your local laws and regulation, funding, and your healthcare structure. In Canada, we have universal healthcare coverage, so NIPT for fetal RHD will be paid by the Ministry of Health for every pregnant patient. However, since the Ministry of Health are under provincial authority, testing might not be deployed at the same time in every province. So, as mentioned earlier by Dr. Clarke, the SOGC position paper was really a turning point for NIPT for fetal RHD in Canada. Of course, we have been looking at the European experience with great interest, but once the SOGC paper was published, we asked ourselves, should Quebec offer NIPT testing? It was clearly within our immunohematology reference lab mandate. We had the scientific and medical expertise within our team. We were familiar with the equipment and technology, and we had all the support teams required to make this a success. Furthermore, we knew it would answer an unmet need requested by our medical community, and that physicians would be willing to collaborate with us. Finally, we knew CBS was also interested in offering this test and that we could rely on each other. Thus, the obvious answer was yes, Quebec should offer this test, and we went on to develop a business plan. So it took us a few months to develop and finalize our business plan, and it was approved by Quebec Executive Board in May 2019. Meanwhile, we had discussion with the Ministry of Health, and we were informed that an evaluation by the Health Quality Council, called INES in Quebec, was required. This was a first-time experience for us at Quebec, so it was a process of discovery. So we made a submission to INES in March 2019, and initially we were told that the usual turnaround time to get an answer was 3 to 6 months. However, considering the major impact on the patient trajectory, a consultation with external stakeholders was requested and organized by the Health Quality Council. Unfortunately, 5 years ago, exactly today, the evaluation was paused because of the COVID-19 pandemic, and the final report was published almost 2 years later in February 2021. At first, the decision was disappointing. The Health Quality Council recommended that fetal RHD genotyping using maternal plasma not be offered. However, they said that this test could be offered to the target population in the event that the method chosen, either a commercial kit or an in-house test, be specified, and that its performance and limitation are determined prospectively through a validation study carried out in real-world care setting. Also, based on this new data, the offer of service is recognized as being effective and safe, and that the costs it entails are acceptable relative to the clinical benefits obtained. While the Health Quality Council was doing its evaluation, we were just considering the different assays available on the market. We had to choose between commercial kits or in-house assays. Early on, we decided that we would not develop an in-house assay, although our R&D department could have done it due to all the licensing requirements. Back in 2019, there were 3 commercial kits available on the market, but none were licensed by Health Canada. The 2 of the commercial kits targeted a combination of exon 5, 7, and 10, while the third one used only exon 4. We decided to evaluate these three assays to see how they perform and compare them to each other. As you can see in the table, we compared the results with the newborn serology. And when a result was undetermined, we requested a buccal swab of the newborn and performed an RhD genotype. Serological RhD results were concordant with the RhD prediction for 15 of the 18 individuals. 2 newborns from mothers of North African origin were found RhD negative by serology, number 6 and number 9. While the cell-free DNA analysis predicted an RhD positive or undetermined result. Subsequent analysis of newborn genomic DNA was performed. For case number 6, a multiplex PCR analysis targeting various exons found that number 6 was indeed RhD negative due to an absence of amplification of all exons tested. However, sequencing analysis was not possible. For number 9, sequencing and multiplex PCR analysis found 1 pseudogene and 1 RhD CE D hybrid allele. 1 newborn from a Caucasian number, case number 15, was found to be RhD negative, while all kids predicted RhD positive. However, subsequent genetic analysis of the newborn RhD was not possible. In summary, given that the recommendation for positive or undetermined result would be to administer RhIG, safety would be ensured. So after the publication of the reports by INES in February 2021, we had further discussion with them and the Ministry of Health to address outstanding issues. And we were very pleased to receive the final mandate from the Ministry of Health in March 2022. So now let's talk about the implementation process itself. Unfortunately, we had to delay the beginning of the project due to concurrent priorities within Quebec, but we are now actively working to implement the test in 2026. This slide is quite busy as it details every step of the project. I won't describe each and every step, but there are 4 important phases. The first one is planning. It should not be underestimated, as good planning will avoid going back and forth and prevent unpleasant surprises. The second phase is the acquisition and validation of the equipment and the method validation. The third phase is the IT solution development, configuration, and validation. The fourth phase involves change management. It includes knowledge translation to health professionals in the community, as well as regulatory training of Quebec employees, leading to the production launch. The last phase is the postmortem and closure of the project. In the next slides, I will discuss some aspects of the second and third phase. When choosing an assay, you should first assess your needs and determine the test characteristic. First, determine whether you want to develop an in-house assay or use a commercial kit. Then, find out which technologies are available and ask yourself a few questions. Is your lab familiar with the technology and the equipment? Is this test used elsewhere? If so, what is the experience? Does the technology comply with your local regulation? Does it need to be licensed by your local authority? Once you have a better idea of what is available, take a closer look at the technical requirements, such as sample volume, storage requirements, shelf life, specificity, and sensitivity. As was explained earlier by Dr. Clarke, high sensitivity is essential to avoid false negative results and minimize the risk of hallucination. You need also to take a close look at performance and stability criteria and considering the transportation time of your samples. Depending on the number of samples your lab will receive, automation and high throughput analysis may be required. Finally, cost has to be considered in your analysis. This slide describes the methodology that will be used by Quebec. The fetal DNA will be extracted from the maternal plasma using the Kia Symphony by QIAGEN, And the assay we will be using is the Divisor RHD, which targets exon 5. This assay is licensed by Health Canada. The final result will be reported to physicians and midwives via the Quebec Health Data Repository that is called DSQ. We will offer testing from the 11th week of pregnancy. As per the manufacturer's package insert, all blood samples are stable for 6 days at room temperature and for 2 weeks when frozen between -18 to -20 degrees Celsius. We will ask a sample be sent from the collection site to Héma-Québec within 5 days to respect the 6-day stability at room temperature. However, considering that Quebec covers a large territory and that weather conditions can be extreme during the winter, we may ask remote site to centrifuge, separate the plasma, and freeze the sample if the delays cannot be respected. Another option would be to use a strict tube. However, at this time, based on our experience for patient samples that are sent to our immunohematology reference lab, we are confident that samples can be sent within 5 days. The other 2 steps when choosing an assay are the equipment and method validation and defining quality indicator. To name a few, you should evaluate turnaround time, specificity and sensitivity of the assay, repeat sampling rate, indeterminate result rate. You should also consider external quality assurance, competency, and proficiency testing. They are now available and strongly recommended. There are also published recommendations for validation and quality assurance of non-invasive prenatal testing for fetal blood group that you can consult. And I refer you to a paper published by Clausen and Colling in Bug Sanguinics in 2022. Lastly, I will discuss challenges and barriers you may encounter. There are many, of course, but I will limit myself to 1 or 2. The main challenge in implementing an NIPT for fetal RHD in our project is really the IT component. As of now, Héma-Québec LIS is not integrated with the healthcare system LIS. We currently use faxes to send our IRL result, which is obviously not viable for high volume analysis. We will perform approximately 12,000 analyses per year or 50 to 60 tests per day. Thus, we need a secure connection to download the result to the electronic health data repository. The first unexpected barrier was the legislation prohibiting Héma-Québec from downloading data to the DSQ. We were successful in having the lab modified. However, there are still challenges for the data transfer from Héma-Québec's LIS to the DSQ. We have to obtain the cybersecurity certificate for our LIS from the government, and we have to develop and validate an interface to download the result. This is underway, but of course, it's a huge development that will take many months. Another challenge you may encounter has to do with the regulatory framework. Thankfully, the Canadian standards for blood and blood components had foreseen the future in their 2020 edition, so no modification is required, but it's an important aspect to consider. So this slide summarizes the different steps we have to go through to implement NIPT for fetal RHD, and we are looking forward to deployment and post-implementation follow-up. In conclusion, we can say that we have achieved success when targeted antenatal RhIG prophylaxis is provided only to those who need it based on the prediction of fetal RHD. NIPT for fetal RHD is available to all Rh-negative pregnant people in Canada. Results are reported clearly and rapidly to clinician and transfusion services. And finally, RhIG use decreased and the immunization rate remains very low. Thank you. And now I will turn to Mr. McGonigal.
Thank you. Thank you very much, Dr. Robitaille, and thanks also to Dr. Clarke. What a terrific presentations you've given, and it's a real eye-opener on an important use for NIPT and an important economy of laboratory utilization, while at the same time fostering great public health outcomes. So this is absolutely wonderful to see. And now I want to introduce to you a little more about our sponsor. Annika Alford is with Devicer. Let me turn my camera on and I'll join her while she. Well, let's see. There I am. Annika, you're ready with us, and Annika Alford is going to share with you just a brief couple of slides. And go ahead and take it away, Annika.
Thank you very much. Yes, so yes, my name is Annika and I'm heading the product management team at Devicer. And I'm very happy to have the opportunity to briefly introduce the company to you today. So Devicer is a Swedish company, a Swedish biotech company that has been around for 20 years, and we are operating globally, and we are providing genetic diagnostic solutions. Yes, and we are specialized in really easy to use kits for complex DNA testing. And we offer these solutions within a broad range of different diagnostic areas, including hereditary diseases, oncology, and also within post-transplantation monitoring. And today I would like to specifically mention the Fetal RHD, which is a product for non-invasive determination of fetal RHD status. And it's a pioneering solution that has been supporting pregnant mothers and women in Europe for over a decade, just as you heard in the presentation. So we're very proud of this solution. And we have different regulatory status for this product throughout the world, and it's cleared for diagnostic use in Europe, Canada, and Australia. And I also would like to mention that we are offering a service through our CAP certified CLIA lab in Atlanta as well. So with that, I just would like to finish by thanking the distinguished speakers, and we are really grateful that we are collaborating with you. And yes, happy that you could present the Canadian story in your journey. So thank you. And with that, back to you, Bob.
Annika, thank you very much. It's a very interesting company, and we'll ask Dr. Robitaille and Dr. Clarke to join us live on camera now. And we'll begin to have some questions. I do know, Dr. Robitaille, there was a slide that you had. Did you want to bring that up very quickly for us once again to show you the Héma-Québec stats and key figures?
Of course I could.
Yes, please do.
So we more or less every year we have around 80,000 births in Quebec each year, and we estimate that approximately 15% of pregnant individuals are Rh negative. Most of our patients are Caucasian. So from that estimate, there's where the annual number of 12,000 analysis per year comes from. So we estimate that by implementing NIPT for fetal RHD, that approximately 5,000 women per year will avoid RhIG prophylaxis at the 18 weeks of gestation. So we plan to do this almost on a daily basis from Monday to Friday, and we expect to communicate the result within 10 days. But since we're doing the test early in the pregnancy, if there are undetermined results or the sample is not adequate, we have sufficient time to ask for another sample and do again the test.
Thank you. Thank you very much. I was glad to be able to share those statistics with you. It looks like there's a very considerable savings that can be entailed here by avoiding prophylaxis where it's not necessary. So I salute you for that. I want to remind our audience, you have a Q&A pod on your screen. You can type in your comments and your questions. Let me first, the first question I want to send to Dr. Clarke. How many labs, as you look at it, would you be planning to establish for fetal RHD screening in Canada and through Canadian Blood Services, if you had your druthers?
Well, I don't really speak for Canadian Blood Services, but
I understand.
The testing in Canada is likely to be highly regionalized. In other words, it's unlikely, I think, that multiple hospitals or institutions would implement this. Rather, I think the economic analyses that have been done in Canada would support the use of a few high volume, high throughput laboratories, similar to what Dr. Robitaille described. And transport is an issue. We have a really big geography, but I think there are solutions to that, some of which Nancy went over, related to particularly the blood suppliers already have supply routes to many rural and remote locations because they deliver blood components to those locations. So that's an avenue for transportation. And in addition, for extremely remote locations or extremely dire weather conditions, there's an option for either freezing the plasma and allowing a slightly longer turnaround time, or the use of Streck tubes. So that's been a matter of big discussion in Canada, whether we should, some countries in Europe just use Streck tubes routinely. And that's a possibility. Then you don't need to do any separation. However, that does increase the cost of the testing because the tubes cost money. And certainly, I'm sure this is true in other countries as well, Streck tubes are not necessarily available in every collection site, whereas an EDTA tube, the same tube that you use for a CBC or a type and screen, is pretty much available everywhere. So from a from a logistical perspective of getting this test easily implemented, it's certainly, there's some value in trying to optimize your turnaround time of shipping and using the tubes that everybody has available. So that was a long answer to a short question, but I don't know how many labs there'll be, but there won't be many in Canada. It'll be a high throughput, high volume process that's localized to a few labs.
Thank you. It should be noted, and just to clarify, Canada has a lot of concentrated central labs where heavy volumes of testing occur and are transported to them, correct?
That's right, yeah.
Very good. Dr. Robitaille, any comments of your own? Do you feel you have one sufficient laboratory within Quebec to do this testing?
Yeah, I think one lab is sufficient. And as Gwen said, we have routes already established with all the hospitals in Quebec. I mean, there could also be a collaboration with NMO Quebec and CBS because of the geography. So we don't think it's going to be an issue, but we have backup plans just in case.
Thank you very much. Annika Alfred, I have a question for you because we want to be very clear here. Could you tell us what the classification is for this test in the EU?
So we have a CIVD clearance in the EU at the highest risk class D.
Thank you very much. So there's no regulatory problem in being able to use the test within the EU.
No, and also in Canada and Australia, it's cleared for usage.
Very good. How long has your CLIA lab in Atlanta been up and operating?
Almost 2 years now.
Okay.
In the summer, it will be 2 years. Yeah.
Excellent. Thank you so much. We have several questions from the audience that I'm sure you would have anticipated, all of you with great expertise in blood banking. Let me ask the first one. Do you use maternal week RHD analysis in conjunction with NIPT? Dr. Clarke, I'll let you ask first, and then Dr. Robitaille, I'm sure I'll have some comments.
Yes, in the sense that we have national recommendations that say that in initial prenatal testing, if the RhD serology is weak or inconclusive, that those individuals should have RhD genotyping. So that is available to all pregnant individuals in Canada, either through Héma-Québec or Canadian Blood Services. And so there's already sort of a pre-established role for RhD genotyping of pregnant individuals that's codified in national recommendations or guidelines from what's called our National Advisory Committee and its partner organization in Quebec. And Nancy can talk more about that. And the testing is available. I don't have stats on whether everybody that has a weak serology has this done, but the proportion would be high. And based on that RhD genotype that is done because of weak serology, recommendations are made by the testing lab as to whether that individual should be considered RhD positive or negative. Basically, if they're if they're weak D 1, 2, or 3, they're considered Rh positive and not at risk for alloimmunization. If they're anything else, they're considered at risk for alloimmunization and would have all of the attendant Rh immunoglobulin prophylaxis testing done. So because that testing is available and has been for some time, most laboratories would confine their Rh negative pregnant individuals to those who were either serologically RhD negative or had had genotyping done and were shown to be non-weak D 1, 2, or 3. And the labs that do that testing are likely to also be the labs that are involved in non-invasive prenatal testing, so they'll be aware of those genotypes. And then I'll turn it over to Nancy for any more operational details.
Dr. Robitaille, would you have another comment on that for us?
Well, no, actually, we are very similar. Although we don't speak the same language, we do the same thing. So it's exactly what Gwen has said.
Thank you very much. Let me ask you, Dr. Robitaille, how were weak D babies classified in the study?
Well, I guess you're referring to the feasibility study we did. We didn't have
exactly
weak D baby, but it's standard care in Quebec to do weak D babies to if an RH baby is born from an RH mom, we will do the weak D test.
Okay, thank you very much. We have another question. I'll start with you, Dr. Robitaille. If a patient was to have a miscarriage, would that previous pregnancy affect the test for the Rh genotyping of the fetus of a current pregnancy?
Well, usually not, because the cell-free DNA titer, if I can say, will lower, and by the time you do the next test, because you're pregnant again, it should have disappeared and should not interfere.
Very good. Would you agree with that, Dr. Clarke?
Absolutely.
Very good. We have another question specifically for the divisor assay. I'll let you bring this to you first, Annika, but obviously we'll hear from our experts after you speak. Specifically for this assay, do you know if there's a correlation with fetal fraction of cell-free DNA? And if yes, is there a lower limit?
Yes, so of course it's important to have sufficient fetal fraction in your test. So there's a range that is defined, and within this range, the clinical results for the clinical sample need to fall within this range. Otherwise, it's considered inconclusive, and that could be due to too low amount of fetal DNA. We do not have, so it's like an inbuilt control, which is done in each sample on the go. So this is really a way to determine that you have sufficient amount of DNA in your test. We have performed in a different context NGS analysis of these of samples that have been tested, and we have seen that even down to below 1% of fetal fraction, this assay still works. Even below 0.5% of fetal fraction, we have very good performance. But this is not kind of part of the product as such.
Thank you very much. And Dr. Clarke and Dr. Robitaille, would you be care to make another comment on that question, or should we go on to something else? Okay, I see you. We have another question that we might have anticipated. What is the sensitivity within twin pregnancies? I'll let you start with that, Dr. Clarke, and then we'll go to Dr. Robitaille.
So I'm going to pass that on to Nancy and or Annika.
Okay, very good.
Well, I don't have specific sensitivity percentage, but I know that in Denmark, they add it's a different acid, but they have done it for twin pregnancies and they had good results. But I cannot tell you a specific sensitivity or specificity.
Very good. Annika, would you care to comment? I know you've surveyed the entire scene.
Yes, so I also don't have any number, but it is it works well with twin pregnancies. So it has been used over a decade in Sweden, and any type of pregnancies has worked fine with a single fetus or also twin pregnancies.
Very good. Thank you. I'm going to ask both of our physicians and clinicians on here a question. This is for your opinion. Why does the clinical routine for managing RHD negative women vary so much? In many countries, fetal screening is the standard of care, as we've heard, while in others, the general administration of anti-D prophylactics is the common practice. Do you have any opinions you'd like to share on that, or shall we just note the fact of the great variability?
Change is hard. So, you know, we have had in developed countries with access to Rh immune globulin a really effective tool for reducing RHD alloimmunization and therefore HDFN. And I think when you have a really successful program, it is, you know, we're cautious clinicians, and so there has perhaps not been a big impetus to make this change. But I think certainly the countries with that are able to afford this change in testing, you know, there's a clear lean towards moving toward this testing type. Like, as I sort of said in my opening remarks, North America is in the significant minority for not having already implemented this. Virtually all other countries with a significant population of Rh negative individuals are doing this testing. So I think the field is moving in this direction. It just takes a variable amount of time to get there. And I think, frankly, the success of the prophylactic program in North America until now has, to some extent, made it a little bit more difficult to change.
Very good. Dr. Robitaille, I'd be interested in your opinion on the same question.
Well, I totally agree with Gwen, but I think RhIG shortage that we've seen in the last few months or years might actually be an impetus to move toward NIPT because it's really a limited resources. I mean, you need volunteer alloimmunized donors. This is really difficult to find those donors, and I think we have to be cautious about them too. So I think the RhIG shortage may actually push forward the implementation of Fetal RHD.
Thank you. Thank you very much. I would note that your slide on the adoption and the incredible results that have been obtained around is sort of a who's who of great public health practice, at least as we generally understand it. And so congratulations to Annika and Devisa for that. But with that, of course, Annika, as I'm sure you know, with newer technologies and newer ways of doing things, we have questions around intentions with this test. So let me ask you, do you have plans or are considering plans for validating the test for red blood cells or platelet antigens also to be found in those cells?
Yes, that's an interesting question. So actually we are, as we speak, working on developing 2 additional products, which will be NGS based, so a little bit more comprehensive. Okay. And for typing a broader range of blood antigens, both one version to type patients and blood donors in genomic, like genomic blood typing, so not non-invasive, but in a different type of context, and then also actually an NGS-based fetal version. So it would be also covering RHD, but also broader other type of blood groups.
Thank you. Dr. Robitaille, a quick comment on that potential.
Well, actually, we had planned from the beginning to have a phase 2 where we would like to add other red blood cell antigens and platelet antigens, but we decided at first that we would go for RhD because it's a huge change.
Right.
But hopefully, once we're more mature, we can add more tests. And I think also the landscape has evolved. 6 years ago, there were no commercial assays for other blood group or platelet antigens. They were really in-house assays. So I think the landscape is changing. We're moving toward commercial assays, so it might be a little bit more easy, might be a little bit easier to implement.
Thank you. And Dr. Clarke, I'll give you the last word by answering this same question to you. Would you be eager to see testing for these other antigens in the fetal scale?
Yes, absolutely. Anybody that's been reading in this field will know that there are lots of jurisdictions that test at this point mainly using in-house assays for other red cell antigens for which antibodies are implicated in HDFN. So Cal, big C, little c. Those tests are available, as I say, mostly in in-house assays, but I certainly think that within the next 5 years or maybe less, that there will be much more opportunity to do that testing. And then in alloimmunized pregnancy, that gives you the opportunity to identify which pregnancies actually need monitoring and which ones don't. So that's, I think, an exciting next frontier.
Well, thank you very much. And as I promised, I'll give you the last word as I begin to wrap up. If there were questions that we haven't got to, we'll certainly get a devicer a spokesperson to answer those. There may be one or two, but I do want to be mindful of our time. Particularly when I'm with blood bankers, I know they like to be very precise. So we'll aim to end at the top of the hour, but not before I thank our wonderful speakers, Dr. Nancy Robitaille and Dr. Gwen Clarke. We've really appreciated hearing from Annika Alford of Devicer. It's a real interesting window into a world that we often don't think too much about in the general pathology practice, but it's very, very important and fascinating for me. So thanks to all three of you. I also want to thank Devicer, of course, for their very important educational support for this webinar. It wouldn't be made possible without that. And lastly, I want to thank all of those in the audience. I know how busy every lab is and every laboratorian is in North America, Canada, and America, and elsewhere for that matter. And so it's a pleasure for us to bring you this kind of programming, and we're very glad that you've shared your time and part of your day to join us for such a great program and other programs that we bring you with the CAP Today webinars. So to wrap up quickly, thanks to Dr. Clarke, Dr. Robitaille, Annika Alford, thanks to Devicer, and thanks to all of you who've joined us today. And with that, I will bring the webinar to a close.